in and out of hospital, which in turn will save a further backlog of patients. The NHS believes that all patients will have the ability to choose whether they want to be treated face-to-face or digitally, have the ability to monitor patients with long-term illnesses at home, and ensure that there are effective movement of patient data in clinical systems. So our final discussion is about transforming patient pathways. I'd like to introduce you to our final panel. We have with us Satya Raghuvanshi, Senior Clinical Lead at Accurex, Penny Ketcher-Gigliu, CCIO at Coventry University Hospital, Dr. Camille Carroll, Chair of the National Institute for Health and Research, and Ridian Hurl, Executive Medical Director and CCIO Digital Health and Care Wales. So very nice to have a full house for our final session 5 of the day. Welcome to all of you. Satya, before we get cracking, could you just start us off by explaining what your communication platform does?
Yeah, absolutely. So for those of you who aren't familiar with Accurex, our vision is really for a health system where anybody involved in patient's care can communicate with each other. It's rather uncontroversial kind of mission and vision that we've got there. So our software really just allows staff and their patients across every care setting, whether that's GP practices or acute community mental health trusts or even hospices, to be able to message patients and to message other healthcare professionals. So we're used for kind of everything from messaging, medical questionnaires, providing appointment reminders and referrals, and also kind of remote monitoring and managing virtual wards. Now, in a very privileged position where we're used by 98% of GP practices and over 50% of NHS trusts, and have been used to message over 50 million individual patients across the UK.
Gosh, those are impressive statistics. So I want to know why not the other 2%, Penny? Satya, I hope that 2%'s on your target list. I'm just teasing you, by the way, but they were very impressive statistics there. Let's bring Penny into the conversation. Penny, why is it so important to look at patient pathways when looking to redesign our healthcare system?
Sure. Thank you. It's great to be here with everyone this afternoon. I will start by saying that during the pandemic, we learned a lot, and we learned that we need to individualize patient care, be more patient-centric, and also look at more about the sustainability of the NHS. How can we empower patients to be treated closer to home, to self-manage? And that requires looking at end-to-end pathways and also linking the pathways together, what we call joined up care, which is the goal of the newly formed integrated care systems. So it's important to have a look at individual pathways from prevention to diagnosis to treatment to follow-up, to see how can we use technology to enable efficient pathways, effective pathways, and pathways that are patient-centric and add value not just to the individual patients, but also to the communities and the population as a whole. And when we talk about pathways, we need to start learning from data, what works and what doesn't, clinical outcomes, outcomes in the community, which are the patients who can access digital technology, how can we enable the people who can't? And step by step, by doing that, we can learn more about what the population we treat needs, empower people skills and have the ability to access their records online, have consultations online, be able to access all the information they need and the right professionals at the right time to maximize self-management and enable the NHS to treat the people who really need to be there in the acute hospital.
I liked a couple of things you said there, Penny. Patient-centric, so important, and also empowering patients, because I think that is one of the benefits of what you're trying to do, that Indeed. Patients do need to feel a little bit more in charge of their own care and to feel empowered. I think that's a word that's kept being used today. Camille, I'm wondering if you agree with that sort of empowerment of patients, and what are the main drivers, do you think, for transforming patient pathways?
Yeah, thank you. And as the others have said, it's a real pleasure to be part of this conversation. It's such an important area of development as we think about bringing digital technologies into care. And I agree absolutely with what's been said. And the way that digital innovation can impact on care delivery, I think there's three broad broad categories. One is to change the content of that care, because using different tools, of course, we can do things to empower patients, whether it's using reminders on an app or information provision in different media in a way that's more accessible to people so that they understand their disease. We can also change the way that we deliver care, as has been said, so that it's closer to home, so that it's in a patient-centric modality of care delivery. That our traditional care models of bringing patients to clinics is very much centred around what's convenient for the organisations, not what's convenient necessarily for patients. And I look after people with Parkinson's. That's a disease of a condition of ageing primarily. So the burden of course, can be quite significant to get into a specialist centre in the middle of a city. And the third thing that digital will bring to our care development of new pathways is understanding diseases with data. And the ability to collect data at scale and in new ways. We will improve not only our understanding of care provision in the way that Penny just said, but we'll also improve our understanding of the conditions themselves. And that will include things like patient-reported outcomes that patients can report through an app on a daily basis or a frequent basis, or it could be a sensor, either a body-worn sensor or a home-based sensor. And these are already impacting our understanding of some long-term conditions, which will ultimately improve patient care.
These are very, very exciting times, Ridian, I feel, and I think that's a sentiment that's been shared by a lot of our guests today. Can you tell us about your vision in Wales and what's going on where you are?
Thank you very much. Nice to be here. As I've been the CCIO in Wales since 2015, healthcare in Wales has devolved, and health and social care is one pot, Helen. It's not a competitive market, internal market, as in NHS England. So first of all, I'd say that there's an approach to collaboration which is beneficial to both secondary, primary and community care. And the vision of a healthier Wales is to deliver patient pathways that are patient focused and not organisation or disease focused. That's done in a number of ways because of a number of problems. And I think it was worthwhile us highlighting the fact that we have to change the way we work and deliver care because of the workforce crisis. We have massive shortages in numerous specialties across the UK, particularly diagnostic services as a good example. We have increasing chronic diseases, and chronic diseases are expensive. They affect quality of life, and they consume a lot of patients' time. And what we've got to do is enable patients to spend more time living life than queuing and waiting in hospitals. And then for the professionals, we've got to maximize the skill mix that we have within the system and obviously retain them and only do what they can do. So divert some of the skills to different professionals to provide equal quality care. So in Wales, we have a number of principles. One is prudent healthcare, what matters to you. And as I've mentioned, because of the demand is beyond the system capacity, the way forward can only be digital enabled.
That's very good stuff. And also you mentioned equal quality care, and that's come up a lot today, when we're talking about digital. Satya, would you say your pathways are they patient focused, and what are some of the biggest challenges with patient pathways that you face?
So I think we definitely prioritise kind of a patient-facing experience to make sure that patients can understand what's expected of them. I think broadly, kind of in terms of what the challenges there are with implementing patient pathways, they typically fall into one of two buckets. One is patient experience, and I think the second is healthcare professionals managing those patients who have been placed on a pathway. And they both stem really from fragmented communication across those services. So for patients, their experiences on a pathway is often very disjointed. They receive information about their care in very disparate forms, in very different kind of communication methods. And that means not only patient awareness of what being on a pathway needs is very vague, but there's also no centralised place for them to collect that information and view it at a time that is convenient to them to then revisit that information. And I think for healthcare professionals, managing patients on the pathways is incredibly challenging. They have to worry about patients being missed, information being lost, managing the volume of different communication channels and systems that they have to use. And I think as we've seen in kind of, the digital health and care strategy, there is a key priority around things like the NHS app as being a front door for patients to access not only primary care services, but also very likely in the future kind of broader NHS services. And I think that's going to be really key to, one, making a more kind of consistent experience for patients, but also making sure that we're giving healthcare professionals the right tools to be able to manage patients on that pathway and move them along very confidently without having to worry about things like retraining entire workforce. So we should be building tech that is very generic. We should be testing that with people who are interacting with that technology and making sure that it solves the problem that they are hoping to solve, and not kind of sitting in a room far away from them trying to think of how we solve their problems.
Penny, you were nodding there. It looked like a lot of what Satya was saying was resonating with you. And I'm just wondering whether she was perhaps alluding a little bit to that whole system approach, and why is that important in pathway transformation?
It's extremely important, and we are talking about joining up care. And as a clinician, I am one only person involved in the patient care. I'm an oncologist, and a cancer patient sees a lot of professionals. And from a primary care perspective, GPs to secondary care specialists, oncology surgeons, to voluntary care people, and people in the community like social prescribers. And how are we going to link all these professionals together to be able, for example, to have conversations with other professionals, to share data about our patients, so to be able to have the right information. If a patient has surgery, for example, in London and comes to Coventry for cancer treatment, how do we link up that care so that the patient gets the right treatment and is confident and trusting the whole system that it's going to work, and the information is there and we are making informed decisions. So I absolutely think it's critical. And if we are talking about care closer to patient homes, we need to think about that broader stakeholders and professionals, like what Redesign mentioned, community workers, social workers, health coaches in the community. How do they come into a whole person model of care? And we are making steps toward that, and technology again is the main enabler to bring all of this together.
In just wondering, Penny, just before I move on, is any examples or any particular pathways that are working really well in oncology that you could use perhaps as an example?
I would say that there is a lot of development around diagnostics and one-stop clinics, where patients with worrying symptoms can actually see a multidisciplinary team, have their triple assessment, and get diagnosed quicker. This is really becoming, there's a lot of development around that area. And diagnosis obviously is one of the main priorities, diagnosing patients within the correct timeline to receive the right treatment. The next step is a holistic model plan for treatment and care for these patients.
And just very quickly,
I was going to come in and add to that.
Go on, carry on, Redesign.
Is that you talked about how can we? So semantic interoperability can deliver information across different healthcare sectors. That's one approach. Another approach is bringing interoperability through common systems. Now, common systems in the commercial world are quite hard. In Wales, as a oncological surgeon, I'm a bladder cancer surgeon. I can see every image on 3.1 million citizens, every single GP record, 211 million test results. I can see their full oncology result. I can read and write into the record, and it's available to 40,000 users. Now, how is it that we can do that over a whole nation, yet we're half the size of Yorkshire? So I think one of the elements we have to say about transforming is the politics, the policy lead, and the culture and the behaviour of the system leadership. And it's worth touching on the fact that the stability within the system is the people on this call, the people who are delivering the care. They tend to be on 20, 25-year contracts. The politicians, they might even change daily, weekly, monthly. And when they change, their viewpoint changes. And what I feel we need is stronger clinical voice in the domains where they decide what's going to change and how it's going to change, aligned with what the patient advocates want.
Do you agree with that, Camille, that what's needed is a stronger voice? Because really, I'm certainly right on the politicians front, particularly at the moment. We're never quite sure where we are we?
Yeah, if ever we needed an example of rapid change.
Yeah.
I agree that the concept of joined up thinking across the health and social care system, starting at the throughout the nation below, at all the various different levels within the different stakeholder groups, sense of joined up thinking. And that will encourage, it will be the driver for these systems to have the interoperability as Reardon described, because often that is almost an insurmountable barrier towards cross-organisational sharing of data. But as Sachi was talking there, and Penny, I was thinking about the value of data and the way it is shared across interoperability. For sure, got huge benefits for patients, but that there is the flip side of having trust in those data processes, the data management and infrastructure that has been created to ensure that data is secure, that people won't have access. And I think there's work to be done there at patient level almost, that people have got to trust that when somebody is entering stuff into their care record in one site, and it'd be fantastic if it is then visible at another site, but they obviously don't want it to be visible at sites where it doesn't need to be visible. And how we build those processes in, I think, is also really important. And there was something else, Helen, that you mentioned at the beginning around in the question around the user voice in the design of the systems, to make sure that they're usable. And again, that is often a barrier. So digital systems, technology systems get put in place. Maybe the organisation has purchased from a particular vendor, or it might even be a patient-driven innovation. Too often, the user has not been involved in the design of it. It's sort of almost imposed. And then you realise this might be the thing for the data managers in the trust, but actually it doesn't work patients because it's completely unusable, and or data system, it's again really counterintuitive how to get the data that you need out of it. So really important when these systems are being developed, that user input into the design of them, whether managed data controllers, patients, clinicians, that whoever is involved in interacting with that user interface, that they are a critical part of the design team, so they're designed fit for purpose.
Satya, it seems very natural to come to you next for a couple of reasons, a couple of points that Camille's raised there. One is the security of sensitive information, and as patients we all feel a bit nervous about where all our information is being seen and being used. But also, when you're developing at Accurex, do you involve patients, clinicians? You know, what's the process to make sure that users are at the heart of what you're developing?
Yeah, but I have to say I'm very strongly aligned with kind of all Camille's points there, because I think it's so critical. It's central to how we build products at Accurex. So we are very much focused around involving users right from the beginning, whether those users are patients or healthcare staff. And we do lots of kind of what we call early testing, even just clicking through very basic designs for staff to make sure that it is very intuitive. We try and build very generic tech. So actually you find that staff pick it up in phenomenal ways. We built this feature that allowed patients to respond to a text message with images, and we had hospital staff using it from the occupational health teams to get photos back of the patient's home environment, so they knew what equipment to take, and so it saved them time, better experience for the patients as well. I think on the data models, it's a really interesting question. It's something that I've probably spent the last 2 years of my career at Accurex thinking about. So we have made records available for primary care, not quite to the extent that Ridian's kind of data sharing programs work, but any healthcare professional that's using Accurex can request a summary of a patient's GP record with the patient's explicit permission. Now, the way that we manage to get around kind of data sharing agreements and things that have typically very hampered those discussions is working very closely with primary care and GP practices, but also involving the late and very great Dame Fiona Caldecott and the National Data Guardian around our approach, which is if a patient is giving direct permission at the point of care for their record to be viewed, should a healthcare professional be able to view it? And the answer is very clearly yes. And so that's the model by which we've predicated and built that functionality. So when you are providing direct care for a patient, fundamentally the heart of that information sits with that patient, and where the GP practice is happy
carry on.
And the patient's happy, that information should be shared. It is a filtered view, it's not a sharing of everything under the sun, but between healthcare professionals, they can view a patient's record.
That leads me, Satya, nicely on to Robin, who says, how do you cope with patients who refuse permission for their health information to be shared? I mean, is that something you come across in the work that you're doing with GP surgeries?
Yes, I mean,
so
sorry, go ahead.
So we have access to 3.1 million GP records, including their medicines, and can move that information across. We work very closely with the general practice community called GPC Wales. We have an incredibly low opt-out, and I think when the conversation is had with the general public and patients that this information is of value to the care that we provide for you, then it's a no-brainer. The conversation gets stickier when we say we're going to use that information in a different way to add value. And when you start to have that conversation, people have two reactions. Well, more than two, I think. One is, what's in it for me? And two, no way. So how you land that conversation, and we've got a good example, and we have care.data, how not to do it, and a more recent example of government policy doing it without really thinking. In Wales, we're landing the data promise, and that's about your information helping you as an individual, your family, your community, think of it as your valley, your region, your nation. And as you go up that tier, you anonymize the information in a way that it cannot be brought back to the individual. And as Caldecott Guardian for Wales, we've delivered a health and social care data sharing agreement across the whole of the nation that allows us to do that. It takes time, and it shouldn't be rushed. That would be, and it's very doable. And information governance is therefore sharing safely, not securing that information so you can't share it.
Just one thought, Ridian, is if something's inaccurate, and I'm just thinking of being in A&E with my elderly father and clinicians saying, we see he's on blood thinners, which he wasn't. Once something's on the system that's actually inaccurate, but could have, an impact on the care you get, is it possible to correct it?
Yeah, it's absolutely editable, because the health record is a chronological timeline.
So if they've got something wrong, you can go and try and get that changed, so it doesn't follow you around. Dennis, I'm just looking at what's coming in from the floor. Dennis says, Penny, bravo. Access across oncology is key. Several solutions are out there to solve this, but how do we get the right stakeholders at the same table?
Very good question. Thank you so much. I think, as Ridian said, we need to get the clinicians on the table, and transforming those patient pathways using technology, clinicians should be on the forefront and working together with end users, the patients themselves, to make those pathways right. But there are a lot of other stakeholders, and obviously our commercial partners, making sure that the systems and the infrastructure we are using is right, and connecting in terms of learning from different providers and learning amongst us is really, really important. But more importantly is, let's learn what our populations are, and what do they need, what are they asking for, why are they coming to clinic for, and let's breaking down, let's risk stratify and apply some population health management to ensure equality and equity of our treatment access and treatment delivery.
Camille, Penny spoke very eloquently about what's happening in oncology and pathways. Your research is focused on neuroprotection in Parkinson's disease. So a bit of a double question really for you. What pathways have you found so far are working for patients with Parkinson's, and how can we ensure that presumably there's a fantastic research opportunity here and that's embedded in these transformed pathways and not lost in the process.
Yeah, thanks, Helen. They're both really good questions. I'll take the second one first. Research is critical, and we've learned a lot about health delivery and challenges in healthcare outcomes in COVID. But one of the things that we learned most of all was the importance of ensuring that research is done well and it's done in an inclusive way, and that the opportunity is available and embedded within routine care. And this is part of the NHS Constitution. It's part of the long-term plan, and very much hope as that the CR to ensure that people accessing health and social care across all nations have access to research opportunity, because it's only by providing that access and having systems built into all of care pathways that we can hope to understand more about health and care outcomes and how to improve them. So a bit like our sort of traditional care delivery model, really, face-to-face contact in a clinic setting or in a hospital inpatient setting. And there are new ways of accessing people and offering them the opportunity using technology, whether it's an app or a telehealth system. So there is the ability to, first of all, make research opportunity much more readily accessible. There are platforms that people can sign be part of research, which will allow people to register their interest in studies. And of course, studies can be delivered in a much more accessible way. They can be delivered completely through an app or through an online web-based platform. And for studies that are maybe evaluating interventions in more vulnerable populations, or where clinical care is an absolutely critical component, then research should be embedded within those care teams. And it's really important that people understand research and research in health and care is a drive health and care quality. And we know that people who take part in research have got better healthcare outcomes than those that don't. Organisations who deliver active research portfolios, those that don't, should be and is in a lot of places just part of good quality routine health and care. So I think it's a really exciting time. There's lots of innovations, digital strategy percolating through all of the work within NIHR CRN, which will hopefully mean that the promise of research and what this can mean for healthcare outcomes across lots of diseases and conditions. In terms of what works well for Parkinson's, again, it's in terms of how time, a really challenging time. Parkinson's is a long several decades, and of course it's a disease, as I mentioned, of aging, so people acquire other age-related conditions and increasing frailty. And I think it's really important that as health and care providers, we learn from each other. So all of the challenges that Satya and Penny and Redesign have talked about, are not unique to any. You mentioned that it isn't a disease-specific or a condition-specific approach that's needed. It's almost a disease-agnostic approach. So learning from others and being able to understand what works is really the way forward.
I've only got 2 minutes left, so quickly whiz round our other three guests. Satya Geraldine says, Satya, is there a directory of pathways on the device that staff access?
So in kind of the primary care facing product, which really integrates with the clinical system, there are a range of pathways that practices can implement, but they can also create their own. So they absolutely are. Geraldine, very happy to pick that conversation up with you after and kind of show you there.
Fantastic. Ridian, quick one for you. Who should be leading this agenda?
It should be a hand-holding exercise. Well, definitely not them. It's a hand-holding exercise between the clinical providers and those that use the service and consume it, so patients.
Brilliant. And Penny, I was taken aback there that you did in such a succinct sentence, because I'm now not going to do any bother and end on time if Penny's succinct too. Penny, how do we know that we're being successful in pathway transformation, ending on hopefully a very positive note?
Well, first of all, by creating the right partnerships and collaborations that was mentioned by everybody, and looking at a common goal and a common vision about equitable access and treatment for patients, we are naturally going to reach and be successful. I think I will end up with collaboration there.
Collaboration is always key. And I tell you what, doing these events, which I've done for a number of years now, always makes me safe in people like your hands. I think we've had some fantastic panelists today, and you've been right up there, all of you, on a fantastic level, sharing lots of information and learnings and collaborating, which is what this is all about. So to my final panelists, to Satya, Penny, Camille and Ridian, thank you so much for taking us out on such a stimulating conversation, and one that you definitely could have continued. Now, whether you are one of our excellent panelists or part of our audience who've been sending in lots of questions, taking the time to listen, or sparking conversations with other delegates, a big thank you from the team here at NHE365. And a thanks to our fantastic event partners, who without events like this simply wouldn't be able to take place. I look forward to seeing many of you at our next event on NHS procurement, which is on the 22nd of September. Please share the word with your colleagues, as we'd love to see even more of you at these events. And if you're a winner in our gamification challenge, then the NHE team will be in touch to discuss your prize options. Separate to gamification, today's event, as you know, was CPD certified, with 1 CPD point earned for every hour of live content watched. So if you'd like your CPD certificate, then all you have to do is email marketing@cognitivepublishing.com. From me and everyone at NHE365, thank you for attending today and giving us your time and attention. I really hope you've enjoyed it. Have a great rest of the day. Bye for now.
Smash.